This conference will now be recorded.
Okay. So today we would be looking at the latest guideline on maternal sepsis during pregnancy and following pregnancy. Now, this is a very important guideline because this is one of the sepsis is one of the causes of death because in the pregnancy, so death, maternal death, and hence it is an important task in MRCOG Part 3, as well as you could expect questions for MRCOG Part 2, right? So for MRCOG Part 3, typically you could have a situation or a scenario which is given to you, which has certain features, clinical features that are suggestive of a possible sepsis. And you may need to explain the management. In MRCOG Part 2, you could be asked questions about antibiotics specific to particular organisms, what organism would be growing in a particular scenario, and hence it is important that you know the presentation associated with different infections. So let's come to what are the highlights of the latest guideline. So you need to consider a woman with a suspected infection and whose clinical condition rapidly deteriorates as possibly a case of sepsis. Okay, so a woman who has an infection and has tachycardia, hypotension, etc., is likely to be a candidate who has or a case of sepsis. So what we need to remember, particularly for the Part 3 MRCOG in our tasks, is that we need to mention urgent escalation. So if it is seen at the community level, you need to urgently refer to a hospital. If she is in a hospital and is rapidly deteriorating, then you would need to refer or you need to admit her in HDU or ICU, right? So monitoring should be performed on an early warning system modified for obstetrics. It's important to note that serum lactate levels need to be done. Okay. Then we need to remember the sepsis care bundle for suspected sepsis. What is also important is administration of IV antibiotics. And that has to happen within 1 hour of suspicion of sepsis, right? So IV antibiotics, sepsis care bundle, lactate levels should not be forgotten. Now, in a critically ill pregnant woman, birth of the baby can be expedited if it would be beneficial to the woman or baby or both. So we often are confused as to what is to be done if there is a woman who is critically ill and she's pregnant, say late third trimester. What is to be done in such a scenario? You need to know that we need to weigh the risk of delivering this patient urgently, maybe by a cesarean section if she's not doing well, versus the risk of doing an urgent intervention when she's already critically ill. So this decision has to be taken by a senior obstetrician. It is not straightforward because anything can go wrong even during the cesarean section. Although having the baby out of her system may help her cope better with the condition, the sepsis, but she may deteriorate during the procedure. So that is why it is not a straightforward decision to consider delivery. So the decision of timing and mode of birth always has to be done by a senior obstetrician, which is something that we must mention in our tasks for the Part 3 MRCOG. Another important feature or another important aspect of management is the baby can also have distress, and which is why we need to do continuous electronic fetal monitoring. They have said that you need to exercise caution while doing fetal blood sampling, and this is because when you are trying to sample the blood from the fetal scalp, you could introduce infection there because the mother is infected, the vagina may be infected, so you could introduce infection in the baby as well. So you need to be cautious while doing fetal blood sampling. An individual risk assessment should be made by a senior anesthetist with regard to the type of anesthesia. The older guideline clearly mentioned that regional anesthesia should preferably be avoided because when we give regional anesthesia, we insert a needle into the spinal canal or into the epidural space, which can introduce the infection up into the central nervous system, which is why it was mentioned in the older guideline that regional should be avoided. But the new guideline does not mention anything specific, but it is said that it is the call of the senior anesthetist with regards to the type of anesthesia, because as a matter of fact, even general anesthesia may not entirely be safe if she is having lung compromise or pulmonary infection, etc. General anesthesia may not be safe either. So that is why the type of anesthesia would need to be decided by the anesthetist itself. Okay. I think there is somebody who is unmute. Can you all please mute yourself? I can hear some disturbance. Okay. Yeah, better. All right. So, babies of women treated for sepsis during labor or in the 24-hour period before or after birth require assessment. Now, regarding antibiotics for the baby, if the mother has group A streptococcal infection, the baby would always require antibiotics, but otherwise you need to assess and look for any clinical indicators of neonatal infection, and accordingly the baby has to be started on antibiotics, right? So the other thing is, yes, if either the mother or the baby is having group A, which is diagnosed, you have done a culture and you have diagnosed group A beta hemolytic streptococcus infection in the postpartum period. Remember, this could be a potential question in the exam, in your part 2 MRCOG exam. Both would need treatment. Both of them would need treatment, the baby as well as the mother. Another important point which is included in this guideline is regarding herpes simplex sepsis. Okay, regarding herpes simplex sepsis. Now, this is included because in the last triennial period, there were 2 deaths, maternal deaths, because of disseminated herpes, and these women may not have rash, the herpetic rash always, right? So if they are not responding to antibiotics, if they have encephalopathy or if they have hepatitis, then you should suspect herpes simplex disseminated infection and perform DNA PCR for herpes. We would be seeing this in a bit, but this is an important point that is included in this guideline. So if they are not responding to antibiotics, remember it could be herpes. You may need to treat with acyclovir. There. Coming to the epidemiology, we have 11% of maternal mortality globally because of sepsis. So this is world over because of sepsis. And between 2019 to 21, 10% of all maternal deaths in the UK were because of sepsis. 10% of all deaths. 14% of deaths were due to COVID-19 infection. Now, remember, as per the latest guideline, this is the second most common cause of admission to ICU. The first common cause is hemorrhage. The second most common cause is sepsis. And as contradictory to the older guideline, the most common infection now is pneumonia. Earlier, it was urinary tract infection, and this may be because of COVID-19 infection and in the recent past, but the most common infection is pneumonia. 44% of all sepsis patients had pneumonia as an underlying cause, right? Now, the last sentence I've included from the older guideline because this is a common question and it may still be asked. It is not mentioned in the new guideline. So, severe sepsis has a mortality rate of 20 to 40%, while septic shock has a mortality of 60%. Severe sepsis is a patient who has multi-system failure, but she's not in shock. Septic shock is where no matter how much fluid you are passing into the patient is not able to maintain her blood pressure. That is septic shock, and that results in 60% mortality. Okay, so this is a common question for the Part 2 exam, and it is included from the older guideline. Now, what is maternal sepsis? So basically, as per the WHO definition, it is a life-threatening condition defined as organ dysfunction resulting from infection during pregnancy, childbirth, post-abortion, or postpartum period. So maternal sepsis is sepsis because of any infection. Sepsis is the multi-system disorder because of the infection, and that arises during pregnancy, a post-abortion, postpartum, childbirth. So any pregnancy-related event that is called as sepsis. While septic shock is the persistent hypotension requiring vasopressors to maintain an adequate blood pressure, alongside a persistent serum lactate level of more than 2 millimole per liter, despite adequate volume resuscitation. So you are trying to resuscitate the woman, but her lactate levels are high and she has hypotension, that is septic shock. Okay, so these are the two terms, sepsis and septic shock. So you have sepsis, which is multi-system problem because of infection, and septic shock, which is basically hypotension, which is refractory to treatment. So this is something that you must remember. Then, as per the latest guideline, it is said that pregnant women are 20 times at increased risk of group A streptococcal infection compared with non-pregnant. So the infection risk or the problems associated with group A streptococcal infection are much more in pregnancy. So they are at risk of invasive group A streptococcal infection 20 times as compared with non-pregnant, and 80-fold increased risk in the postpartum period. Right? So this is something that we need to remember, and this is one of the common causes or the common bacteria that results in death. These are the risk factors. I don't think we need to go through this because most of us would know this. Remember, obesity, diabetes, this can be asked in a structured discussion for your part 3. Also, you can be asked in an MCQ for part 2. So you have obesity, diabetes, iron deficiency anemia, advanced maternal age, impaired immunity, women of ethnic minority, renal, cardiac, or liver disease, history of pelvic infection in the past, contact with somebody who is carrying the group A streptococcal infection, IV drug abusers. And obstetric causes or the risk factors would be prolonged rupture of membrane, cesarean birth itself is a risk factor, vaginal trauma, retained pregnancy tissue, amniocentesis and other invasive procedures, multiple pregnancy, cerclage. So any intervention you do in pregnancy can result in sepsis, remember. Okay, so then moving on to the type of organisms. So we have the most common organism is E. coli. And where do you get E. coli? Which is the infection which is the site where you get E. coli infection commonly in pregnancy. Can anybody tell me? Yes?
UTI.
Yes, excellent. So UTI is we have already seen is currently the second most common cause, but overall UTI has always been the commonest cause, but in the last 3 years, it is pneumonia possibly because of your COVID-19, but otherwise UTI is one of the most common causes. So E. coli is the most common cause of sepsis, and then you have your beta hemolytic streptococcal infection, and these two are important causes of death. GBS is also an important cause of sepsis, but it is not associated with deaths. Yes, please note that GBS causes sepsis, causes morbidity, may not be associated with deaths. This is for the mother. We're not talking about the baby. The baby may cause fulminant sepsis and death, but for the mother, it is usually morbidity and no deaths. Okay, so the common causes would be E. coli, which is the topmost cause, and beta hemolytic streptococcal infection. PVL producing staphylococci are also associated with mastitis and breast abscess. These are also quite common organisms. Remember, mastitis and breast abscess. Staphylococci is present on skin. So it is very easy for staphylococci to get access to and result in mastitis and breast abscess. Okay, so right. So we can have situations that may be provided to you where the patient is having chills, rigors, myalgia, febrile illness, fever, and has rash or wound infection. When there is rash or wound infection, remember it is one of the cocci. Okay, staphylococci or streptococci. Okay, so you have staph, which is again a skin organism that can infect the wounds, and streptococci can cause serious septicemia. Okay, as we have seen, gram negative is with febrile illness, usually is urinary symptoms. So UTIs, we need to consider the possibility of viruses, influenza, as well as HSV. And if there is a history of foreign travel, we need to consider parasitic infections like malaria. All right, let's see a certain clinical scenario. Okay, so here we have impetigo, tonsillitis, cellulitis, flu-like symptoms, diarrhea, vomiting, rapid deterioration, systemically she is not well, disproportionate pain. This is an important sign and can be given to you in your clinical scenario that is mentioned to you in the question. This comes for part 2. Okay, and late onset after pains. What does this mean? After delivery, you usually experience some amount of cramping because of the uterine contractions immediately after delivery, which should pass off by 12 hours. However, if the pains persist, lower abdominal pain persist, which do not subside with analgesics. These are buzzwords that would be there in the question that you are given in your part 2 exam. Severe abdominal pain. What could this organism be? Anybody? Anybody? What is this? I'm giving you the clinical scenario. Tell me the organism. What? Anybody? Excellent. Yes. So it could be your group A streptococcus. Excellent, right? So coming to the next one. Recurrent skin infection, history of contact with recurrent boils or abscesses, abscess severe mastitis, we've already seen this. Scars from previous incision and drainage. So it's something that stays on the skin and causes breast infection. Which is this? Anything on the skin is? Staphylococcus or your PBL producing staphylococcus. Okay, so this is another organism that we must remember. All right, then you also have severe respiratory infection, hemoptysis, cavitation, and massive effusions. Lung infection. Anybody? Which is this organism? Of course, all of them can cause all these symptoms, but there are specific organisms that have specific presentation. So which is this organism? Yes, yes, one of them is TB. Also, PBL producing S. aureus. One of them is TB, and the other one is PBL producing S. aureus, Staphylococcus aureus. And why? Because it causes cavitatory hemorrhagic pneumonitis. PBL producing. So remember, PBL producing Staphylococcus causes mastitis, abscess in the breast, and abscess or hemorrhagic lung disease as well. So in the lungs. Okay. So remember, one of these two can cause hemoptysis. Okay, remember the word, the buzzword would be hemoptysis. There. Flank pain, dysuria, fever. Organism?
E. coli.
Yes. Excellent. So you have your gram negative producing extended spectrum beta lactamase and carbamazepine producing enterobacteriaceae. These are called as CPE and ESBL. So enterobacteriaceae, which is also gram negative, and your beta lactamase producing gram negative organisms, which would be E. coli, Klebsiella. Okay, so these are the gram negative organisms which can cause dysuria. So you have flank pain, dysuria, fever. Okay, you also have dysuria, urinary retention. Can anybody tell me what this is? Vulval or sacral pain, paresthesia.
Herpes.
Excellent. HSV. Okay, so this is something that you must remember. And I think you should get a question on HSV because it is mentioned that this is um, uh, in the last 3 years there have been 2 deaths in the UK because of disseminated HSV, which went unrecognized because they all thought that it is bacterial infection, bacterial sepsis, and that is why we have a new HSV guideline as well. Okay, now IV drug abusers, septic emboli, vasculitic lesions, stigmata of endocarditis. Which organism?
Staph epidermidis.
Yes, excellent, excellent. So you have your most of it is MRSA, Staphylococcus. Basically, it could be gas as well. Staphylococcus. See, and on the skin you have staph and strep. Okay, so IV drug abusers would introduce the skin organisms into the IV lines, and it would reach the heart and cause endocarditis. So MRSA, PVL producing organisms, and your group A streptococcal infections. In immunocompromised patients, also you can get these infections. You can also have HIV, HPV, and HCV, which you need to test in these individuals. Okay. There is a question: in only suspected or all cases of sepsis do we test for HSV? No, we test if there is suspicion of HSV in the first place. Also, it is recommended now in this guideline that we test for HSV DNA PCR if they are not responding to your antibiotics. So when you consider the first change of antibiotics, because there is no response to the first line antibiotics, that's when you consider testing and treatment with acyclovir as well, and particularly when there is hepatitis, which is associated with disseminated HSV, and when there is encephalitis. Okay, so diarrhea and vomiting, crampy abdominal pain is associated with, it's already given there. It is associated with Campylobacter, Salmonella. Okay, and it can be an early feature of toxic shock syndrome. Okay, the exotoxin which is produced by streptococci can affect all systems, and diarrhea and pain is a common sign. Clostridium difficile happens. What is the condition? Anybody can tell me what is the condition that is caused by Clostridium difficile? Anybody?
Pseudomembranous colitis.
Yes. Yes. Excellent. Excellent. So, yes, it is associated with use of antibiotics. When you use antibiotics overzealously, that's when it disturbs the gut flora, and there is growth of this particular organism, which is Clostridium difficile. You can also have diarrhea because of viral infection like norovirus. All right, then. Okay, this is a common question for part 2. I think everybody should answer this. Unpasteurized milk, cheese, undercooked or cured meats, which is the organism.
Listeria.
Listeria.
Listeriosis.
Excellent, excellent. Okay, so we have listeria. Okay, the organism with unpasteurized milk and milk products like cheese is listeria. You also have others like Campylobacter, Salmonella, and Q fever and all those. But the common question that is asked is listeria. Okay, so yeah, hemorrhagic rash, purpura. Anybody?
Strep, ma'am. Strep.
Okay, good. So you have strep, which is gas. You have pneumococcal and meningococcal also. Remember, meningococcal causes that hemorrhagic rash all over and symptoms of meningitis. Okay, so that as well, all streptococci basically. Okay, so hemorrhagic rash. Then, okay, chorioamnionitis. What is the common organism in chorioamnionitis? One of the common causes of sepsis, which is the organism.
E. coli, ma'am.
E. coli.
All right, you're not wrong. I would say it is mixed. Okay, gram positive and negative as well as anaerobes because it typically goes up from your vagina. So it has multiple organisms mixed. It is E. coli, yes, gram negative, gram positive as well, and anaerobes are also associated. So that is why we always add an anaerobic cover when there is suspicion of chorioamnionitis, typically with metronidazole. Okay. This is something that is repeatedly mentioned in the guideline. What is this? Conjunctival suffusion and sunburn rash is associated with
Toxic
commonly
shock
with
syndrome.
yes, toxic shock syndrome with
Cephalococcus toxic syndrome.
staphylococci, that is Staph aureus. 100% of them would have sunburn rash. So it is like mottled appearance of the skin. And streptococcal 50% have sunburn rash. And this is given in this particular guideline. What another thing that you must remember is that there are blisters with. I'll give you the answer. This is your hemolytic gas infection, and the vaginal discharge is watery. It is not purulent. It is watery vaginal discharge because the streptococcal exotoxin destroys the leukocytes. So it is not rich in leukocytes. It is not purulent because puripus is basically dead leukocytes. It is more of watery discharge. Okay, so remember this also can be a buzzword in the exam. Watery vaginal discharge. Okay, then. So another important scenario they can mention again in the exam, part 2 exam, is that a patient comes repeatedly to the GP after delivery, say with say certain complaints of pain or which is not subsiding, the after pains are lasting longer, suspect sepsis, referral to obstetric triage, okay, and can be considered as a red flag sign. Okay. Of course, there can be other conditions that could masquerade as sepsis, which would be preeclampsia or other rare conditions like TTP and hemophagocytic. These are certain conditions which are mentioned, lymphohistiocytosis. You don't need to memorize them, but there are other conditions like particularly commonly preeclampsia, which can look like sepsis. Okay, so must remember those as well as differential diagnosis, basically. So they have now given certain red flag signs, and if those red flag signs are present with suspicion of infection, if there is infection suspicion and these red flag signs, you should suspect sepsis and start the management, that is sepsis 6, in response to red flags. If there are amber signs, you need to review by a senior obstetrician within an hour and then consider whether it is sepsis or not. So first let's see the red flags. So what are the red flags? So the GCS is uh, not excellent, so not good. It is a patient is not alert on your ABPU classification. Okay, so when you check your sensorium, then the patient doesn't seem alert. She's a little drowsy. So that may be one of the signs. The patient is a bit drowsy. Remember in your part 3 exam in the labor ward prioritization room, sometimes they give you a particular patient is drowsy. Okay, always suspect sepsis, please. Always suspect sepsis. Then respiratory rate more than 25, oxygen saturation less than 94 on room air, heart rate more than 130, systolic blood pressure less than 90, urine not past urine in more than 12 hours, or if catheterized, the urine output is less than 0.5 ml per kg per hour. Okay, so around normal for a 60 kg person, the urine output per hour is 30 ml. Okay, so if it is less than 30 ml, it would be abnormal, or less than 0.5 ml per kg per hour. All right, so these are certain red flags that may be mentioned in the Meows chart that is provided to you in your exam. Okay, and you may need to say the steps that you would take in order to treat this particular patient. So remember, she's not alert. She is tachypnic, having respiratory rate of more than equal to 25. Saturation is less than 94. Heart rate more than 130. Systolic less than 90. And she's not passed urine in more than 12 hours. Or if catheterized, it is less than 0.5 ml per kg. These are red flags. Let's see what are the amber. So you have behavioral or mental status change. So a little bit, she's a little disoriented, you can say. Acute deterioration in functional ability. She's not able to function well. And these are the objective signs. Respiratory rate, there it was 25 and more. Here it is 21 to 24. 100 to 130 is the heart rate. Systolic BP, there it was less than 90, here it is 91 to 100. Urine output not passed in last 12 hours, or if catheterized is somewhere in between 0.5 to 1 ml per kg per hour. It was less than 0.5 per ml per kg per hour previously. Here it is 0.5 to 1. So to repeat, respiratory rate is 21 to 24, heart rate is 100 to 130, systolic blood pressure is 91 to 100, and urine output is between 0.5 to 1 ml per kg per hour. All right, continuing with the Ember signs. I think there's a spelling mistake. Ember signs. So you have, there is suspicion of infection, and she's undergone an intervention in the last 6 weeks. Okay, so here again, you need to look into this. You cannot ignore a patient who has, say, mild fever, and she's undergone surgery related to obstetrics in the previous 6 weeks. So you should not ignore any fever for that matter in the postnatal period or in pregnancy after an intervention. All right. So if you know that she's having an impaired immune system, like she's on steroids or she's having HIV or other immunocompromised state. Temperature is, there is fever more than 38 or less than 36. Okay. Now remember, fever is not an absolute requirement, but I mean, what I'm trying to say is there need not be fever in sepsis. Okay, although it is a manifestation of infection, but you can have patients without fever. So don't think that if there is no fever mentioned in the question, patient is not likely to have sepsis. Okay, so don't look out for fever. It is not even mentioned in the red flags. Remember that. So then current diabetes again compromises the patient's ability to fight infections. And when you know that patient has had a close contact with gas. Prolonged Rupture of membranes, we all know that this is an important risk factor. 18 to 24 hours if she's had rupture of membranes, and prolonged vaginal bleeding and abdominal pain after birth. So remember, when a patient, if there is a clinical situation that is given to you in the question in part 3 exam, patient has delivered, patient has now come, she has continuous bleeding and she has pain. Please think of sepsis. Okay, you need not have fever, but you need to think of sepsis. You need to review, you need to check her vitals, you need to check her, take her cultures, that is her bacteriological samples, that is your vaginal smear, and your vaginal swab, and your blood culture possibly. Okay, so all of that has to be done, and you may need to do imaging as well, like an ultrasound, to check if there is any retained products of conception. So these are the such clinical situations can be asked in the exam. Okay, offensive vaginal discharge, definitely you would need to look for infection, we look for sepsis. Okay, so this is the chart which is mentioned. So what do we have here? The first step is, if the patient is looking unwell, you look for risk factors for sepsis. Like if there is impaired immunity, is there any recent surgery, any indwelling lines, etc. Look for risk factors. So if she's unwell, or if you have been monitoring her on a Meows chart for whatever reason and she's not doing well, you need to look out for risk factors. So then next question that you ask yourself, could this be an infection? So always think sepsis. Okay, even in the current guideline, in the first page of the guideline, it is mentioned that what you need to do is you need to think sepsis. So always think of the possibility of sepsis when there is an abnormal presentation in pregnancy. Okay. So if you have thought of sepsis, ask whether there is infection. Number 2 is, could this be an infection? If so, where do you think the infection is? Is it respiratory? Is she having cough? Is she having tachypnea? Is she having RS findings like your crepitations? Is she having breast abscess? Examine the breast. Okay, so all of these points also are important for you to say in your exam. Okay, look for the breast examination, whether there is any erythema, any rise in temperature, any swelling on the breast, any discharge. Urine, is she having urinary symptoms? Any hematuria, urine routine, and leukocytes, nitrites can be checked. Any abdominal pain that she is having or distension that she's having, it could be intra-abdominal infection as well as your endometritis. Then if she's having infection at the wound site, always look for episiotomy or the cesarean wound site. Very important. And you look for evidence of vaginal infection, endometritis. So that's important. So if you think it is sepsis, next check whether there are red flags or if there are any amber flags. Okay, if there are red flags, you will start the sepsis 6 bundle. Okay, so immediately think of sepsis. You don't really have to diagnose sepsis as such by proving that it is an infection. No, you need to just have your red flags. If there are red flags, you need to start your sepsis 6. If it is amber, then you need to further have the patient reviewed by an obstetrician. Okay, so further clinical review by a senior person within 1 hour, and you need to send your blood for testing and review the result. Okay, so that is why they have divided these signs into amber and the red flag signs. Okay, so remember the red flags, and any other presentation that does not fit into the red flags, but you think it could be because of infection, you can say that I would like to rule out sepsis, I would like to rule out an infection, I would like to seek consultant review if there are amber signs. If there is red flag, you would definitely say that I would start sepsis 6 care bundle. Okay. Fine. So these are non-infective causes that can look like sepsis. Okay. So you could just go through this particular chart. Yeah, any one red flag, if you have, Dr. Mahmood, if you have any one of them, you can start sepsis 6 bundle. This is when you are suspecting. So remember the first step, second step. In the first step, second step, you are suspecting infection. Like she has, say, she's come with temperature of 99, and now you have checked her, and you find that her pulse rate is very high, say 140 beats per minute. You need to start the sepsis 6 care bundle, even if there is one single red flag. Okay. But in what you need to remember is that you are suspecting infection. You are suspecting sepsis, uh, as the first step. Okay, and then you're looking for red flags when you have already suspected infection. Okay, so right. So then recognizing sepsis. Sometimes it could be because of disseminated, as we have, as this particular guideline emphasizes that it could be influenza, it could be disseminated HSV, it could be a COVID. Okay. HSV hepatitis is responsible for, HSV is responsible for 2 to 4% of acute hepatitis in pregnancy. Okay. And HSV should be considered. This is what I need you to remember. This HSV needs to be considered as a causative agent in women where there is a failure of first-line antibacterial medication. If a pregnant woman presents with acute febrile hepatitis, so first line has failed antibacterial medication, because the first thing you would think is bacterial infection. If there are no herpetic lesions, the first thing you would think is a bacterial infection. So if the first line has failed and there is febrile hepatitis, so she has fever, she has evidence of hepatitis, and with markedly raised ALT, SGPT levels, markedly raised 10 times, normal bilirubin, typical. Okay, so look for all these signs in the question that you are given. Bilirubin is typically normal in herpetic hepatitis. What is very high is ALT. Okay, encephalitis or disseminated, often vesicular skin lesions or a combination, but the skin lesions may not always be there. Okay, so encephalitis, hepatitis, first line has failed. Always think of herpes simplex virus infection. And what you need to do is acyclovir has to be started when you consider the first change in antibacterial regime. That means you first start, say, piperacillin, tazobactam, and clindamycin. These are the first line medications that are started for sepsis. So if you start that, and then you think that the patient is not improving, and there is fulminant hepatitis, there is encephalitis, there is some rash, you need to think of herpes simplex. At the same time, you need to change her antibiotics if she's not responding to the first line, because there is almost always superimposed infection with bacteria. Okay, so yeah, so this we also know that women of minority ethnic background, Asian, Black, are at higher risk of developing sepsis. Okay, so urgent escalation, as we have already seen, urgent escalation has to be done. If you are in the community, refer to hospital. If you are in the hospital, she is rapidly deteriorating, please admit her in HDU or ICU. Remember, pyrexia is not always present. That's important for you to remember, because don't think it is not sepsis because there is no fever. Typical mistake. Okay, so fever may not be there. Now, this is something I would want you to know. One is about the HSV, and this is another interesting thing, is as stated by the MRCOG 2023, post-delivery streptococcal infection, particularly gas, is most likely to be present within 12 hours post-birth. So immediately you'll have this infection. Infection should be suspected and actively ruled out for women who have recently given birth and experience significant pain and persistent bleeding. Okay? After pains typically reduce in the hours after birth and do not develop after discharge from the hospital. So the after pains or the cramps that you get after delivery would disappear within a few hours after birth, and she would not have them after discharge. But if she has persistent pain, you need to suspect gas infection. Okay, so pain after a vaginal birth does not settle with simple analgesia. So all of these are buzzwords. Does not settle with analgesia. Okay, and such women, you need to look at her abdomen and do a vaginal examination if indicated. If you think it is infection, please do a vaginal examination and collect the necessary bacteriological investigations, including a vaginal swab. Okay. So what are the investigations otherwise for sepsis? We all know we have to do blood culture, and remember the safety point that blood culture, the blood has to be drawn before giving antibiotics. Always the blood has to be drawn before giving antibiotics, because if you give antibiotics, then that blood culture that you draw may not show any organism because you've already given antibiotic. Also, they have recommended that you draw blood twice. Okay, so draw the blood twice, and because the possibility or the probability of getting infection or getting an organism grown when you draw blood twice is more. Okay, consider HSV PCR. We have already seen in which cases. Okay, and also if you are suspecting right in the beginning, you do HSV PCR. Serum lactate. Okay, serum lactate of more than 4 should prompt immediate escalation of care, and a critical care team should be involved. Okay, so this is important. Any relevant imaging, very important. Like you may need to do an X-ray if you're thinking of, say, pulmonary infection. You may X-ray chest. You may need to do an ultrasound pelvis if you're thinking of a collection, or if you're thinking of retained products of conception or retained bits of placenta in the uterus. Or if you're thinking of a pelvic abscess, you may need to do a CT scan. Okay, so these are the various modalities that you may need to do. You may need to take other microbiological samples like we've already discussed. If there is persistent cramping, persistent bleeding from the vagina, you may need to collect swabs from the vagina. If you are suspecting urine infection, you may need to take urine sample for culture sensitivity. So this is what they mean by other microbiological samples. Other than that, routine blood tests, because it's a multi-system disorder. Remember, sepsis is something that affects all the systems, including your liver, your renal system. So you need to do a full blood count, ABG, that is blood gas analysis, for lactate and glucose as well. Coagulation screen, because you can get DIC as a result of sepsis. So coagulation screen is important. Okay, you can get coagulopathy, remember. You can get renal failure, so urea, electrolytes, creatinine, liver function tests. C-reactive protein is a marker of infection. Okay, it is high in bacterial infection, but it may also be high in viral infections. Venous blood gas for glucose and lactate should be done. You need to do appropriate virological tests, okay, as we have discussed, SARS-CoV, and throat swab for bacterial culture. In tonsillitis and pharyngitis, you can expect your gas infection. If the patient is at risk of MRSA, nose swab. So these are some common questions that may be asked. Pre-moistened, nose swab. If she has diarrhea, stool culture. You may also need to look at her platelet count and a rising CRP, and this may be one of the points in the question. There is high platelet count and the C-reactive protein is rising, and there is swinging pyrexia. What does this mean? Swinging pyrexia is typically seen in abscess. Abscess. So abscess, which may be because of an infected hematoma. Okay, so this is what you can get as a question. Okay, again, consumption of soft cheese or cured meat, listeria. History of travel could be parasites like malaria, typhoid, cholera, viral hemorrhagic fever, and brucellosis. And hospitalization is associated with MDR, multi-drug resistant organism. So you need to look at all of these factors and inform the laboratory, and this is important for us for answering our questions. Okay. What is the difference between procalcitonin and C-reactive protein? Remember, C-reactive protein is high in bacterial sepsis. Typically, you will be given a station in the part 3 exam where they would give you this C-reactive protein value, which is high. You need to suspect sepsis, and but it is not specific. It is high even after surgery. So even after a simple cesarean, it may be high. So remember that. If otherwise the patient is absolutely fine and she has higher C-reactive protein, she's undergone a cesarean, it may be just because of the surgery, okay, or it may be because of something like DVT. Okay, rarely with viral infection also it can be high. Now, procalcitonin, on the other hand, helps in differentiating bacterial and viral infection in non-pregnant women. So, procalcitonin rises in bacterial, not so much in viral, but that is in non-pregnant women. What happens in pregnancy? It may just rise even in labor or PPROM. So again, both are not specific. Okay, they are not specific indicators of sepsis. They may just rise. Okay. So it's important that you involve MDT. This particular word is important. Multidisciplinary advice, particularly for Part 3 MRCOG. When you do your tasks in the exam, you need to say that when the patient is critically ill, you would involve a multidisciplinary team. If there is a suspicion of sepsis and it is amber, the amber signs are present, then you would involve your senior obstetrician or your consultant for review. Okay, but if she's critically ill, you would need to involve your senior clinicians, which include your obstetrician, your anesthetist, senior midwife. So it would be a multidisciplinary input. You may need to involve your radiologist as well as your microbiologist. So management is, we all know very well. So that's sepsis 6. What do? Administration of IV antibiotics, broad spectrum, within 1 hour. This is important. Within 1 hour. Early resuscitation with crystalloids, particularly if your lactate levels are more than 4. First, you give 500 ml to pregnant women. All of them are, what is mentioned in the guideline is if she's less than 16 years of age, you would give 20 ml per kg per hour. But if she is more than 16, so almost all of our obstetric patients, you give 500 ml crystalloids. Okay, so you give crystalloids 500 ml and you look for the urine output. If she's maintaining adequate volume, that you would come to know depending on how well the urine is flowing. So that if the urine is flowing well, that means the blood flow to the kidneys is fine. Then choice. Now, which antibiotic to choose? This is important. This may be asked. Which is the antibiotic? The first line antibiotic. See, the first time that you see a patient and you're suspecting sepsis, you have to start antibiotics within 1 hour. You don't have your culture sensitivity. So the antibiotics that you start are not started based on culture sensitivity. They are empirical. What is empirical? Empirical means you do not wait for culture sensitivity. You start directly. So now what is the recommendation? It depends on your local epidemiology. So locally, what is growing more in your local in your region, and which organisms are resistant? Depending on that, there has to be a local protocol for antibiotics in your hospital. That is what is recommended. Okay, and if there is fever in labor, as we know, according to the GPS guideline, we have to include antibiotic regime for GPS, benzathine penicillin, and CTG monitoring for the baby. So the common antibiotics that are used would be piperacillin, tazobactam, or meropenem, which is for your gram-negative cover, and clindamycin, which gives gram-positive as well as anaerobic cover. Your piperacillin, tazobactam, and meropenem also covers positive, organisms. And clindamycin is important, particularly important because it shuts down exotoxin production by the streptococcal bacteria. Okay, so that is why clindamycin is very important in sepsis. So clindamycin and piperacillin tazobactam or meropenem can be used. If there is history of MRSA in a woman, if you know that there is some history of MRSA, you have to start vancomycin. The other antibiotic is teicoplanin in MRSA. Okay, vancomycin or teicoplanin. All of these are important questions. Okay, then what is mentioned is if there is GPS infection, do not use clindamycin for prophylaxis because it is the resistance is rising, 31% resistance, which is quite high, 1/3. Okay, so if you have not done sensitivity, don't use clindamycin. If you have done sensitivity and you know it is sensitive, then you can use clindamycin. So if you're suspecting GBS, do not use clindamycin. Okay, you can use other antibiotics. So yeah, and this is also what we have seen earlier. If a change in antibiotic regime is considered because of deterioration despite first line treatment, consider the addition of IV acyclovir. Okay, this you can consider even if your HSV DNA results are not out, because remember your HSV DNA results can take time. So here you can empirically start IV acyclovir as well. And regular senior clinician review. This is important. Sepsis 6. First is, there are 6 steps, right? So the first step now is ensure senior clinician attends to the patient. Okay. So, so they have mentioned that not all patients with red flags will need the sepsis 6 urgently. So you can wait for the senior clinician to come and then start. And depending on, say for example, it is not sepsis, it is say HELP syndrome, but the presentation may be same. Patient is not doing well, or orientation is patient is drowsy, patient is having hepatitis like features, mild fever. You don't know whether it is sepsis or HELP syndrome. So you need to have your senior clinician attending to the patient. But for all practical purpose, if you have doubt, please start sepsis 6 care bundle. So in the exam, when there is red flags, you will say that sepsis 6 care bundle will start, and you say that senior clinician will first review the patient. Okay. Then oxygen. All right. Oxygen has to be started and aim for a saturation of 94 to 98. Okay, so start if the saturation is less than 92. Obtain IV access. Take the blood for all those investigations that we have mentioned, particularly your blood culture. After blood culture, give your IV antibiotic, and it has to be given within 1 hour. Then you give IV fluids, and then you monitor. Okay, so when you monitor, you have to monitor the urine output as well. Very important. Okay, so in sepsis 6 bundle, what we give is your oxygen, your IV fluids, and what we give is IV antibiotics. Okay, what we draw or what we take from the patient is your blood culture. Okay, your lactate,
Cathetered
and
urine.
urine. So there are 3 things given, 3 things out. Okay, so this is at least this way you can remember that these are the various components of sepsis 6. And remember, senior clinician has to attend. Okay. Then, what are the indications for transfer to ICU? Anything which is severe, any severe form of sepsis. So she's hypotension, her serum lactate is persistently more than 4 and requiring vasopressor support, inotrope support, always refer to ICU. Respiratory, pulmonary edema, need for mechanical ventilation, need for airway protection. Obviously, you're going to require ventilator, so ICU. renal replacement therapy, that means she requires something like dialysis, you would need to take her to ICU. Decreased conscious level, she may just stop breathing because of the conscious level is decreased, then you need ICU. Multiple organ failure, uncorrected acidosis, hypothermia, all are indications for taking the patient to ICU. Okay, so let's see specifically what happens, because these are the things that are specifically mentioned in this latest guideline. So very few patients have perineal colonization of GAS. So 0.03 to 0.06% of pregnant women. So not very high. Okay, so you need to know that these they can have perineal colonization of gas. But if there is infection, then the first thing that you will have is vaginal discharge, which is watery. Leukocytes are destroyed by gas leukocyte, in which we had discussed earlier. And therefore, what is the problem here is because it is not offensive, it is not purulent, it is just watery. So you may not take it seriously, but you need to take it seriously. Okay, it can cause endometritis, it can cause myonecrosis, that means necrosis of the muscle of the uterus. It can cause peritonitis, it can cause streptococcal toxic shock syndrome. Very important. Okay, so that's one thing. Then the other one is necrotizing fasciitis. The necrotizing fasciitis is also caused by your gas. And what is important here is it is pain. You may not have signs on the skin outside. Inside there is pain. There is severe pain not responding to analgesics, culminating in opioids. So we have repeatedly mentioned um, all these buzzwords is culminating in opioids. Then your changes in the appearance of this wound, that is, the wound may start looking like it is bruising. It is mentioned in the guideline clearly that if after a say cesarean or any surgery that you do, it is very unlikely that after a few days of healing, suddenly you will see that there is bruising. Okay, initially you see immediately there is bruising, it may be related to your surgery, maybe there is a bleeder there. But if after a while, say after 4 or 5 days, you find that there is bruising on the wound, suspect necrotizing fasciitis because of group A streptococcal infection. Very important. Again, all of these words or all of these situations can be given to you as a clinical situation, and you need to identify the organism. Okay. This is antibiotic management of, so you may be asked about the antibiotic spectrum in the exam. Okay, so we know that coamoxiclav is active against streptococci, staphylococci. Okay, it is active against your cocci and some many gram negatives, but not MRSA, not Pseudomonas. Okay, not MRSA and not Pseudomonas. Okay, metronidazole is always anaerobes, always anaerobic cover. Okay, that is why it is given in PID as well, because infection in the tube can is because of mixed infections usually, including anaerobes, just like chorioamnionitis is mixed infection. Okay, then clindamycin. Clindamycin currently covers most of your gas, and it is important because exotoxin production is shut. Okay, but most, not all of the gas organisms. GBS is only 67%, as I told you. 30% is resistant. Okay, it does cover most other gram-positive staphylococci, including many MRSA as well, and anaerobes. Okay, so it switches off exotoxin production. This is something that is important, a feature of clindamycin, which may be asked why it is used in sepsis. First line is because it shuts down exotoxin production. So it will prevent toxic shock syndrome, because toxic shock syndrome is because of an exotoxin production. It is not renotoxic. So in sepsis, one of the first organs to fail is the kidney. So you can give clindamycin safely. It is not toxic to the kidney. Okay. Piperacillin tazobactam is again the first line for sepsis, and it covers most of your gram-positive, most of your gram-negative organisms. And unlike coamoxiclav, it covers Pseudomonas, but it does not have any activity against MRSA. And it is renal sparing in contrast to your gentamicin, which is an aminoglycoside. Okay, so both your first line medications are safe with the kidneys. Okay, so but piperacillin tazobactam is not good for MRSA, and also ESBL producing coliforms. It will not act. Okay, so I know this may be a little, difficult to grasp, but remember, piperacillin and tazobactam, clindamycin are used first line. That means they will be active against the major organisms, your GBS, your staphylococcal infection, okay, your gas infection. But what you need to remember is that against MRSA, we have special antibacterial. So these are not effective against MRSA. And your ESBL producing beta lactamase inhibitors. So I mean, basically your beta lactamase producing organisms. They are lactamase is basically beta lactams are these penicillins and penicillins and cephalosporins. So they destroy these antibiotics. So they are not effective against beta lactamase producing coliforms. Then you have your cephalosporin. Okay, what is the question? Antibiotics regime needed for RCOG3 is the same antibiotic. This is what you need to say. Piperacillin, if it's a structured discussion. If it's a simulated patient task for part 3, you need not take the names of antibiotics. But if it is structured discussion, piperacillin, tazobactam, and clindamycin. Okay, that is the combination. And if you are suspecting MRSA because of, say, previous, she is known to be a carrier of MRSA, you will add vancomycin. Yeah. Yeah, septic abortion, it would be different because yes, gentamicin is given in septic abortion, metronidazole and your coamoxiclav usually, but you can even give pibzoclinda, that is your piperacillin, tazobactam, and clindamycin. Then coming to your cephalosporins, you are typically using ceftriaxone as your cephalosporin. Again, because it is beta-lactam antibiotics, the beta-lactamase producing organisms will not be affected. Pseudomonas is not affected, and your MRSA. But it will cover the other group A and group B streptococcal infection. Now, carbapenems are very broad spectrum and they cover most gram-negative organisms, including the ESBL. So, the carbapenems are effective against your beta-lactamase producing coliforms, okay, and anaerobes as well. Remember, your cephalosporins and piperacillin is not effective against ESBL. Carbapenem is, and it doesn't cover MRSA. MRSA, most of them would not be effective against. Clindamycin affects some of the MRSA. It does have some effect on MRSA, but mostly it is vancomycin, teicoplanin. Okay, so it covers most gram positives except MRSA, and obviously carbapenemase producing organisms, enterobacteria carbapenemase producing will be resistant to carbapenems because they are producing carbapenemase, which is an enzyme that destroys carbapenems. Okay, your gentamicin mainly cover gram negative, most pseudomonas. So as we have seen in various places that pseudomonas is not affected by all those first line, gentamicin may be needed when you have pseudomonas. Okay, so which is the antibiotic for pseudomonas? Gentamicin, one of the first line antibiotics. Okay, so gram negative, remember, gentamicin is the antibiotic. Vancomycin, MRSA. Okay, vancomycin is MRSA. Remember that. This is a chart again, which is mentioned in the guideline. The ones in yellow are given orally for mild infections. The ones in gray are the IV antibiotics, which are used for your infections, okay, your sepsis. All right. So if you can see, your gentamicin is for gram negatives. It is having some activity against your staph and MRSA. Clindamycin has some activity against MRSA. It is mainly used for the straps and the staph, but there is rising resistance to gentamicin. Sorry, to clindamycin. Okay, your cefuroxime, cefotaxime, your tazobactam, and your meropenems are all for strepto and staphylococci, which is why they are used as your first line sepsis regimen. Okay, then another thing that you need to know is for pseudomonas, another antibiotic is aztreonam. Okay, and these are for MRSAs, but specific for MRSA. Linezolid as well, remember that. Okay, your vancomycin, teicoplanin, linezolid, daptomycin. Metronidazole is always anaerobes. Okay, so this is what you need to remember for your exam. Now, another thing which is very important for part 3 particularly is allergies. What happens here when you have mild, like patient says, I'm allergic, one of the questions that you ask in your part 3 exam for your simulated patient task or even structured discussion is patient is allergic or not to any of the medicines. And she says, yes, I'm allergic to penicillin. Do we always switch to cephalosporins, or I mean, do we always switch to other antibiotics? It depends on what is the manifestation of allergy. So if it is just mild rash that she has experienced, which happens in most commonly, then there is a 1 to 3% chance of cross reaction with cephalosporin. So in most of these cases, you can use cephalosporins. Okay, so if she has rash with penicillin, does not mean she will have rash with cephalosporin. Just 1 to 3% chance of cross reaction. That means in 1 to 3%, penicillin rash will also be associated with cephalosporin rash and carbapenems. Now, anaphylaxis. If there is anaphylaxis, it's important that you avoid all cephalosporins, all carbapenems. Okay, so then you have to involve your infection specialist and other antibiotics like erythromycin, clindamycin, vancomycin may be appropriate alternatives. So when there is allergy to penicillin, ask the question what kind of allergy. If it is mild allergy, then you can use cephalosporin, but remember there is 1 to 3% chance of cross reaction, carbapenems and cephalosporin. If there is anaphylaxis to penicillin, do not use cephalosporins and carbapenems. You can use clindamycin, vancomycin, erythromycin. Okay, so that's important. Then IVIG is used only in the sickest women. So there is nothing working. You can use IV immunoglobulins. And contraindication is immunoglobulin A deficiency in the mother. Congenital immunoglobulin A deficiency. Fetal management basically in and timing of birth. In the critically ill pregnant women, as we have already seen earlier, birth of the baby can be expedited if it would be beneficial to the woman or the baby or both. Okay, so it is not clear cut, because if she's so sick, the woman is critically ill, even the process of birth can put her life in danger. But at the same time, we must remember that getting the baby out, and if she sustains through the labor process or through delivery process, cesarean process, then getting the baby out may also benefit her. Okay, so both ways she may have benefit, but the problem is that during the process she may deteriorate. Okay, so the decision about delivery, the mode of birth is pretty difficult in these situations, and that is why you need to involve your senior obstetrician. So as an ST5 in the exam, when you approach a task, As far as birth, delivery in severe sepsis is concerned, do not commit to a particular answer. But if she's critically ill and then the baby is viable and is doing well, you can mention that we could consider cesarean section because the patient is critically ill, but she has to be stabilized first. If she's in hypotension, you cannot take her for a cesarean section. You need to stabilize the patient and see if she's responding and then take her for a cesarean section. Okay. If there is preterm birth, you need to give magnesium sulfate for the baby. And remember, you can consider steroids for the baby's lung maturity. It's not like steroids would be contraindicated because there is infection in the mother. Not necessary. It is just the cover that you give for the baby's sake only for that time. It's not chronic exposure to steroids. That is why it is not contraindicated. You can consider steroids. During the intrapartum period, continuous electronic fetal monitoring, caution during fetal blood sampling. We have seen this already. An individualized risk assessment by a senior anesthetist regarding the type of anesthesia, which is differently mentioned in this guideline. Earlier, they had said regional is contraindicated, but here, I mean, regional is unsafe, but here you do not, they have not mentioned anything specific. So you would need to say that it is to be individualized, the assessment. And mode of birth should be individualized. Whether you are going to consider cesarean, whether you're going to consider vaginal delivery depends on various factors. Okay, depending on how well the patient is doing, depending on her patient preference, how far is she in labor, whether she's already in advanced labor or not, what is the gestational age, how is the fetus doing. All of these factors have to be taken into account before you decide on the mode of delivery. Okay. So neonate, remember, as far as antibiotic prophylaxis for baby is concerned, you do not directly start, but you assess the baby if there is infection in the mother or sepsis in the mother within the 24 hours prior. And however, if the mother or baby is having gas infection, both should be treated. I repeat, this is a potential question. Both should be treated. If mother has gas, doesn't mean you observe the baby only. You need to treat the baby as well as the mother. If baby you find that there is gas infection, you treat the mother as well. Okay. So intrapartum antibiotic prophylaxis for GBS, I repeat, in case of maternal pyrexia in labor has to be mentioned. Okay. So these are important points. Postnatal care. Postnatal care, all pregnant women should be mentioned, should be told about the signs and symptoms of genital tract infection. So every time you discharge a postnatal woman from the hospital, you need to tell them and warn them about red flags. Okay. Any gas identified during pregnancy has to be treated aggressively. So any infection with gas bacteria that you find in pregnancy, you have to treat. And another important point to remember is household contacts and healthcare workers that come in contact with respiratory secretions can be considered. Okay, so it's not always done. Considered depending on how close you are with the patient. Antibiotic prophylaxis. So these are important points as far as gas infection is concerned, and gas is a notifiable infection. So remember, you have to inform the UKHSC. So you have to notify the infection control team. Okay, so that's important that you inform them. All right. So with that, we wind up with today's session. Any difficulties you can ask. Right. I hope you've understood. It is a dry topic. I know it's a little bit too much to take in, and all those various presentations, etc. And the antibiotic spectrum you need to memorize. So there's no way out, but it
Ma'am,
is
Ankita,
still an important topic. Yes, dear.
it's very good, ma'am. Can you please upload to YouTube? Like it will be very
Yes.
helpful
Okay.
for all of the people.
All
Ma'am,
right.
I have
All right.
another question. There was a
Cool.
part 3 station. The
Mm-hmm.
girl is she's 20 and 18-week patient, and IVF pregnancy. She has water leak since 2 days. There is no fever, no pain. ultrasound anhydramnios is there, baby is fine. Blood
Correct.
test,
Yeah.
WBC is raised, and CRP. She wants
Yes.
to
Yes.
continue pregnancy. So this will come in sepsis, ma'am.
She has only days counts, right? There is no other
Yeah,
feature of.
yeah,
There is no
ma'am. Clinical.
tachycardia. There is no fever. There is no mm, no tenderness or pain,
No, ma'am.
right? No offensive
Yes,
vaginal discharge. All of this has to be checked with the patient in history and
yes,
examination. Okay.
yes.
Once you know that this is ruled out, you need to
Mm-hmm.
counsel the patient that since she has leaked at very early gestation, there is
Mm-hmm.
leaking, right?
Yes,
So
yes,
first of
ma'am.
all, patient must understand there is a very high chance that she may deliver. Now, it may be a
Yes.
miscarriage on
Mm-hmm.
spontaneously. You can't do anything about it because she's
Yes,
leaked too
ma'am.
early, right?
Mm-hmm.
You cannot put a stitch. You cannot do anything. So she may miscarry is the first thing that you would need to counsel her. Secondly,
Okay, ma'am.
if she does want to continue because this is a precious pregnancy, there is a chance that that the uterus can get infected, the baby can get infected. Even if she pulls on, she may still have early delivery, preterm delivery, and we cannot guarantee as far as the baby's prognosis or outlook of the baby. That's what you say in your lay language. Baby's outlook
Yes.
is concerned. There is a chance of early delivery, even if you continue. Okay?
Okay, ma'am.
You
Okay,
need to
ma'am.
tell her about the significant risk of infection. I think the age of the patient, this patient was more, I'm not sure, but uh, there is a significant risk of infection. And if the infection happens, she will not only lose the baby, it would be life threatening for her as well. But you need to
So,
tell her
ma'am,
if she
yeah.
does choose to continue, you would
Yes.
monitor her on a regular basis. And if any sign of infection that arises, you need to consider termination.
Yes, ma'am. Ma'am,
Okay?
one of my
Yeah.
friend told her we need to admit you
Mm-hmm.
today. So patient got very angry.
Mm-hmm. Mm-hmm. You need not admit all leaking patients. You need not admit all patients that are leaking. But if you think that there is a risk of that you need to monitor her for signs of sepsis, then you need to
Okay.
admit her.
Okay,
So
ma'am.
it's you can say in this particular scenario where the leukocytes are slightly increased and nothing else is there, you can just make a mention to her that we could, after discussion with our consultant, we could consider admission to evaluate and to check if there is any ongoing infection because that
Okay, ma'am.
can result in rapid deterioration. If we find
Okay,
that it is fine and all your investigations are fine, we could consider an outpatient management for you.
okay, ma'am.
Okay? Yeah.
Okay. So, ma'am, as in sepsis, you told us the 44% is pneumonia. So the new talk of COVID
Mm.
is important. It can come as structure discussion, right?
Maybe it can, but I think mostly you'll get sepsis only. You may not get because COVID is a passing infection. I mean,
Yeah.
it's like now it's not prevalent, so you may not get on
Ma'am,
COVID
in
as such. You will get
yeah.
mostly as sepsis.
Ma'am, in 6 weeks course, are you covering this recall that I'm telling?
Yeah, yeah. So all of these May recalls are actually we are going to not May, yeah, November recalls, I think. November
Yeah, yeah.
recalls are currently we are doing them. Okay, we are putting them up on the library and we are also going to upload them on MRCOG. Okay, so we are still in
Okay.
the process, but we will definitely finish by next week. Okay,
Okay. Thank you so much, ma'am. It was really nice
yeah.
listening to you.
Thank you so much. Thank you for patient listening, all of you. Thank you. Good night.